Hello, and thank you for joining us today for our program, Stroke and TCAR, in honor of Stroke Awareness Month. My name is Elena Wiesner, and I am the Director of Marketing and Business Development at McLaren Bay Region. And today I have the honor of introducing Dr. Nicolas Mouawad. He is a vascular surgeon at McLaren Bay Region, as well as the Chief of Vascular and Endovascular Surgery and Vice Chair of the Surgery Department at McLaren Bay Region.
Thank you so much, Elena. Thank you for that kind introduction, and thank you all for joining us today in order for Stroke Awareness Month. We're going to talk about carotid disease and about stroke, which is really important for us to discuss. As you can see here, every 4 minutes, on average, 1 American dies from stroke. There is 750,000 people with strokes per year in the United States, and as you can see, there are 130,000 deaths per year from stroke. Although it's the third leading cause of death, it's the #1 leading cause of disability, what we call morbidity. And we'll break this down a little bit more in the next couple of slides, but in the lower left-hand corner, you can see that almost 90% of strokes are considered ischemic. And that refers to a blockage type of a stroke where you lose blood supply to the part of the brain. Those are overwhelmingly the most common, usually from a blockage in the neck or something from the heart ending up at the level of the brain. 15% of those are actually a stroke secondary to a bleed, so a kind of a bleed in the brain, which can cause a significant neurologic or brain type deficit. The symptoms are relatively clear, and it's important that you and your loved ones are aware of these. You can have eye symptoms or trouble with the eye on the same side where the brain's affected, or on the opposite side if it's using your paralysis, hands or feet. That tends to confuse a lot of people. The left side of the brain takes care of the right side of the body, and vice versa. The right side of the brain takes care of the left side of the body. So it's kind of opposite, except when it comes to the level of the eye. Importantly, though, is this. You need to be fast, because time is tissue, and the sooner we can intervene, the better it is for long-term outcomes. So remember to be fast. B for balance. Look for any sudden loss of balance. I for any trouble with your vision or loss or lack of vision. If the face looks unusual or you have a drooping corner of the mouth, that can be a sign of a stroke. If your arms are hanging down or obviously losing function of your arms or legs. Most commonly, we see patients present with slurred speech or drooling. And of course, if you have a terrible headache. And importantly, if any of these are occurring or you notice any of these, call 911 immediately, and remember to be fast. When you come and get evaluated for a stroke or a mini stroke, as we call a TIA, a variety of tests can be done. We need to make sure your heart is okay, and ultimately we get either an ultrasound of the blood flow to your brain or a CT scan or an MRI, which can show us pretty definitively if there is areas of the brain that are no longer receiving any blood supply, and therefore causing a stroke. The carotid ultrasound is very easy to be done. It's painless. It's non-invasive. They place a special device, as you can see there in the picture, called a probe at the level of your carotid artery. And we take a look at the carotid artery to see if there's any significant blockage. And ultimately, they generate a report. It comes to us. We review the report and try to take a look to make sure that the blood flow is okay to the level of the brain. Usually the reports, which tends to confuse a lot of our patients, is less than 50%, 50 to 69, and more than 70, kind of like mild, moderate, and severe. How much less than 50 and how much more than 70? That's where the interpreting physician comes in, and they can take a look at the more specific numbers that we look for. But again, this is non-invasive and painless, just putting a probe, kind of like what happens when pregnant ladies take a look at the uterus and at the baby. When do we refer, or when should you be seen by a specialist? Any symptoms of a stroke, like we saw earlier. Of course, in that previous category of be fast, you need to be seen very fast in the emergency room. If we can see any evidence of a blockage in the carotid artery or any of your scans, you should need to be seen and referred to a specialist. And ultimately, of course, if you have any signs and symptoms of a stroke with a blockage more than 50, or if you have no signs and symptoms of a stroke, but your arteries are blocked more than 80%, that's when you should be seen generally by your vascular surgeon who can provide care. But again, if you have any symptoms of a stroke, you don't wait to see your doctor in the clinic. You go immediately to the emergency room, call 911, because time is of the essence. Why refer to a vascular surgeon? Well, vascular surgery refers to dealing with blood vessels, whether it's the arteries or the veins or lymphatics. And at McLaren Bay Region, and definitely on our service, it's a collaborative effort. We work together with you and your families to come up with the best treatment plan. It doesn't always necessarily mean when you see a vascular surgeon that you have to have surgery. We do a lot of medical management, putting patients on appropriate medications that are evidence-based. Sometimes you may require some minimally invasive type of procedures, like catheterizations, and other times you might require something a little bit more complex or open surgery. So being able to provide that large gamut of care, whether it's medical, minimally invasive, or open, your vascular surgeon can do that for you. Again, the goal here is to partner with you and your loved ones, and as well as your primary care physicians, to come up with the best and most comprehensive management plan for you, okay? And then ultimately, of course, early referral is very important. We want to know what's going on so we can come up with the best plan and not have something come up too late where we might not be able to take care. So it's important that you make sure that you see your vascular surgeon. Of course, we're all part of the Society for Vascular Surgery. So like I said earlier, just because you're seeing a vascular surgeon or you see us at our facility doesn't necessarily mean that you need to have surgery. Not everybody with blockages in their carotid arteries, or even people that patients that have stroke, necessarily need an operation or surgery. Importantly, we got to make sure that you're on the appropriate medication, make sure that your blood pressure is under control, stop smoking, make sure that your cholesterol is appropriate, be as healthy as possible and as active as possible. And then we like you to be on aspirin to help protect your blood vessels from any further disease whenever possible. I get a lot of questions about this. The goal of medication actually is to avoid your blockages from getting worse. Generally speaking, the medicine will not take away the level of blockage that you have. The goal is to avoid things from getting worse. Removing the blockages usually requires some sort of intervention or some sort of procedure. So who gets surgery? Anybody with signs and symptoms and a blockage over 50% that we see either on your ultrasound or that we see on your CAT scan. Those patients require to have something done because we want to avoid you or your loved ones from having a second episode, which could be debilitating or even fatal. But most patients that we see have blockages in their carotid arteries without any symptoms at all. And so not everybody that has a blockage necessarily needs to have surgery. And so currently, at least in the United States, what's accepted is a blockage over 80%. Earlier, we spoke about those three categories: less than 50, 50 to 69, and more than 70. So patients that we see, that I see, with a blockage of 70%, 75%, don't get surgery. You have to have over 80%, generally speaking, in order for us to see some sort of a benefit. And again, the specific numbers that your vascular surgeon or interventionalist will review will help us make that decision together as a group and as a team with you and your family. The traditional method is called a carotid endarterectomy, or a CEA. And that basically involves scraping out the disease from your carotid artery. You'll come to McLaren Bay. We will put you to sleep, generally speaking. You'll have brain monitors on, you'll have heart monitors on, and you will have an incision on the side of the neck where the carotid artery is located. We, or I, or one of the surgeons, will find the carotid artery itself. They'll open up the artery, and then also you can see that in the middle portion of the screen here. I'm going to put the mouse, which is the plaque. All this plaque is blocking the blood flow, which is this, towards the level of the brain. And we don't want that to be this way. We want the artery to be nice and big so the blood flow goes to the brain and you don't have any blockages. And so that happens with you asleep. We remove the blockage or scrape it out and then ultimately reconstruct or repair the artery and sew it back together. You will spend a day in the intensive care unit for close monitoring. And if everything goes according to plan, you get to go home the next day. Here you can see the neck of a patient. This is actually their body, and this part's their head over here. And this is the incision on the side of the neck that tends to have to happen in order to find the artery. And this is what we remove. That's the kind of blockage that you see, almost 2 inches of a blockage of the blood flow going to the level of the brain. And then ultimately the artery gets reconstructed and the blood flow is okay. And like I said, you spend a day in the intensive care unit for close monitoring just to make sure everything is fine, and then you get to go home the next day. Nowadays, there is a newer way to treat carotid disease, and it's called TCAR, which stands for transcarotid artery revascularization. It's a long, complicated medical term, but the short term is TCAR. And that is a combination of a X-ray procedure with an incision, so what we call a hybrid position, which I'll show you in the next couple of slides. But not everybody qualifies for this, although things are changing relatively recently. Primarily, the treatment was for high-risk criteria, and there's a variety of categories for that. Primarily, age greater than or equal to 75, severe neck immobility, previous surgery in the neck, previous carotid surgery, and other things such as severe heart disease, recent heart attack, severe diabetes, and so forth. There's a variety of categories. Although just recently, it has been approved for what's considered standard risk. So for people that can undergo a regular carotid endarterectomy or scraping procedure, this procedure has now become available for those with what we consider a standard risk indication. This is a video of the procedure. It's by Silk Road Medical, who is proprietary for this TCAR procedure, but I'm going to just go through this with you all so you can see how the procedure is generally done. This still we tend to put patients to sleep here at McLaren Bay. You get an incision at the level of the collarbone, and I find the artery itself. Once the artery is identified, we put an IV in the artery, if you will, what's called a sheath, and then through that, we can start taking our pictures to see where the blockage is and what we need to do. If you can see with the cartoon there, the flow is now reversed. This is what tends to worry a lot of people. We actually start reversing the flow from your brain and putting it in your leg. And this way, there is no blood flow going to the level of the brain at this time where you could have a stroke. And so this allows you to have a very, very small, minimal stroke rate. And all the blood gets filtered into this device at the top part of the screen that I can show you right here. It's a filter. And as the blood comes out, we place a special stent. And then once we place the stent and we're happy with it, we restore the blood flow to the level of the brain in the standard fashion. And then we remove the IV and close the hole in the artery. And so it's what's considered a hybrid procedure because it has a combination of a stent as well as an open, very small incision at the level of the collarbone. On this next slide here, again, just for those of you that are not familiar with this, the black color is the flow of blood. And this is actually you can see, I'll use this mouse here. This is actually teeth over here. And this is the flow of blood. You can see here the severe narrowing. This is a nice wide open blood flow. And this one's severely narrowed. This one happens to be the blood vessel that goes to the level of the brain. And so it's severely narrowed over here. And that's not good. It could be causing strokes or ultimately cause some trouble. So after we place a stent, you can see how it's now opened up quite big. And that's because the stent is now placed. I'm just trying to find the mouse. You can see that. The stent's placed over here. So if you look at here, nice and very plugged up. And then ultimately over here, it's open. It's now the blood flow goes to the level of the brain. And now this is done with a very small incision. And look, this is what we find in the filter. Every single one of these little specks can cause a stroke. All of these can cause a stroke. So this is all filtered out by what we call the reverse flow or neuroprotective technique that protects the brain from these small little specks or pieces of plaque that can be very, very dangerous. Clearly, we want to avoid that. And so here I just have some representative pictures. You can see this is what the incision looks like. At the level of the collarbone, it actually hides underneath your shirt or your sweater. It's almost like you never had anything done. A very small incision at the level of the collarbone, at which point we place the IV, if you will, which allows us to place the stent. This is a patient, actually, that had a previous carotid endarterectomy done. You can see the incision here. And many, many years down the line, the blockage recurred again. And so instead of going through that old incision, which increases your risk of some nerve injuries, we went in a different area here where the TCAR was done. And then through this incision, we placed that IV and placed a stent to treat the recurrent the recurrent narrowing that he had at the level of his carotid artery to avoid him from, God forbid, having a stroke. And so this is the TCAR incision. And this is the traditional open incision. Like I said, after surgery, you spend one night in the hospital. I know you might feel great. I know you might feel awesome and you want to go home. That is something that doesn't change. You need to spend one night in the hospital to make sure everything is okay. And like I said, if everything goes according to plan, which we expect it to, you get to go home the next day. You can go back to regular activity in around a week. I try to let patients take it easy for a week because after all, you have an incision on the side of your neck. So if you're trying to turn your head while driving or something, you want to make sure that you're not a danger to yourself or others. So we try to take it easy for around a week. And in 3 to 4 weeks, you come back to clinic. We get a repeat ultrasound to make sure that the treatment worked the way it was supposed to. And then you're basically on your way. We tend to check it every 6 months or at least every year for a couple of years to make sure everything looks okay. And then that will be it. You still need to be on your aspirin. You still need to be on your cholesterol medication because medicine is just as important as the surgery. We are a center of excellence here at McLaren Bay Region, one of the few in the state of Michigan. We do a lot of this advanced procedure TCAR in addition to traditional CEA or the scraping of the carotid. So we do a lot of those at our facility, and we are recognized as a center of excellence. And as you know, McLaren serves over 97% of Michigan's population with multiple facilities around the state. So you can see here for referral or appointments or questions, there's our number at McLaren Bay Heart and Vascular, 989-894-3278. And we're happy to take care of you or your loved ones, or of course, happy to answer any questions for those of you that are watching and may have some.
All right. Well, thank you so much, Dr. Mouawad. Fascinating information, especially that video. I had no idea, even working in the hospital and promoting this, everything that goes into the TCAR procedure. So thank you. Our first question that we have is from Gina. She would like to know, how long do you have to wait after stroke before a patient can get TCAR done?
Yeah, that's an excellent question. So it's been a topic of debate in the literature for quite some time, but the concept here is we have to look at the risk-benefit ratio. So primarily what's accepted now is usually between 2 days and 2 weeks if you've had a stroke or a mini stroke, at which point we want to do an intervention. We have to balance the risk of doing an intervention so quickly, where you have a risk of bleeding in the brain, with the risk of waiting too long and you might have another stroke. So it's been something that's been debated quite aggressively in the literature for many, many years. But again, what's accepted now is between 2 days and 2 weeks is when we like to do an intervention if you've had a stroke or a mini stroke.
Okay, great. Patty would like to know, what are some modifiable risk factors that she can share with her grandparents or grandparents about how they can change their diet to help lower their cholesterol?
Yeah, that's also an excellent question. I think and that hits it right on the head. Medical management is the most important here. So, I said aggressive blood pressure controls, very important. We want to avoid episodes of high blood pressure as much as possible. Being on a cholesterol medicine, we get this question a lot. Even if your cholesterol is normal, even if it's normal, being on cholesterol reducing medications are very helpful because they have anti-inflammatory, or what we call pleiotropic effects to help with that. So I see a lot of patients that tell me, hey, my cholesterol is normal and it's fine. I understand that, but it's been shown that if you have carotid disease and a variety of other vascular disease, such as disease in your legs or aneurysm disease, that being on a cholesterol medication is very helpful. In addition to stop smoking, being as healthy as possible. I know it's difficult with the, U.S. diet to sometimes not eat as healthy as we would like. I think everything in moderation is probably a thing that I tell my patients as much as possible. I mean, I'm not going to deny you from or restrict you from eating fried food, but if you eat it all the time, it's going to make it a little bit more challenging, particularly with significant hardening of the arteries.
Gotcha. Good to know. So our next question is from Grace. She wants to know, what is the rate of stroke after having TCAR rather than having a carotid endart?
Yeah, again, also a very good question. I think that's important to just tell everybody. One procedure is not better than the other. Right? That's, if one was better than the other, we'd be doing one all the time. So I think that's very important to keep that in mind. There are specific patients that qualify for doing TCAR. There are some technical considerations that are necessary for the surgeon to be able to do it. So it doesn't, just because you might qualify for a TCAR because of, your age or whatever it may be, sometimes it's just not possible. The shape of the carotid is difficult. The neck is not long enough. So there are some anatomic challenges that might make it a little bit more difficult to do. The stroke rate with the TCAR in their latest trial actually was 0.6%, which is extremely low, the lowest out of anything actually for management of patients with carotid disease. That is something I really want to point out. The point of surgery is to avoid you or your loved ones or the patient from having a stroke. But don't forget, the risk of surgery is a stroke. Somebody has to stop the blood flow to your brain to fix it. And that's what we do, or that's what I do for a living. And the rate is very, very low, but it's not zero. So these all have inherent risks of stroke, heart attack, and death. They also have an inherent risk of injuries to the nerves. So they're not all foolproof, but with TCAR, the rate of stroke is 0.6%, which is the lowest out of any intervention for carotid disease. The rate with carotid endarterectomy should be less than 2% is what is accepted nationwide.
Gotcha. So basically the best medicine is prevention, to not have to have these procedures at all. So
of course, as with any of our health-related troubles, of course. But yes, if we can do something and be proactive about avoiding this and being preventative, it's much better than a reactive methodology. I absolutely agree.
Gotcha. Okay. And it looks like Gina has one more question. This will be our last one. Is a second stroke, so if somebody has a second stroke, is it typically more severe than a first stroke?
Not necessarily. Everything of it is challenging, of course, because the brain does not regenerate any of its material. And so not necessarily a second one is more significant than the first one. It could be the other way around. But the goal again here is if you have a stroke or a mini stroke, we need to identify why that happened. Is it a stroke because of blockage, or is it a stroke because of bleeding? Is it from the carotid, or is it from your heart? Is it from something else? And just to point that out, 30% of strokes, we don't know why they occur. It's what's called cryptogenic. So we search for everything, and if we can't find something, we'll put you on a blood thinner for a couple of months just to make sure that we're not missing at all. But 30% of strokes we cannot find. But for your question, the second one not necessarily will be more significant than the others. So I know it's the middle of the day, and I know you all may or may not be busy, but if I was unable to answer your questions, or you're seeing this at a later date, or you're not looking at this live, if you guys have any questions at all, please feel free to ask questions in the comment box, and they'll get them to us or our facility. I'll be happy to answer these for you whenever possible, or review you or your loved ones. We're happy to take care of you, and thank you for trusting us with your care.
Awesome. Thank you so much, Dr. Mouawad. This has been super informative, and we really appreciate you taking the time out of your schedule to speak with our public. So
thank you, Elena. Thank you guys so very much. I really appreciate the opportunity to help.
Excellent. All right. Well, we are really excited about a couple of programs that are coming up. Specifically, we have a skin cancer screening that we haven't had since 2019. So we're very much so looking forward to that. That event is going to be held on June 24th, which is a Friday. And you can register by calling toll-free 1-877-411-2762, and we can go ahead and leave that in the comment section. We also will have it up on our website very shortly, if not already. It was supposed to go up today, but we have a number of other educational events and screenings, so we welcome you to attend. And thank you so much for joining us today. Take care.